All right, let's hop back in. Yeah, great. Okay. All right. Everybody's in here. Okay, so getting back into bipolar disorders. Okay, so there are actually a couple of different types. So there's bipolar 1 and bipolar 2. We'll talk about how we classify those differently. It's mostly to do with which type of symptom is dominant. So bipolar disorder is a disorder that is categorized by swinging back and forth between two types of episodes. So we have manic episodes, which is this sort of, as it says here, a continuous elation that are out of proportion to the setting, include irritability, very high sustained levels of energy, and an expansive mood. Okay, so we talked about positive and negative symptoms. Manic episodes are going to be positive symptoms. Again, positive not meaning good in this case, but just things that weren't there before but are there now. So things like high self-esteem, sort of these delusions of grandeur, reduced sleep, increased talkativeness, just a flurry of activity, easily distracted, physical agitation, and then the really big one is poor judgment, a lack of inhibition. So might go out and buy like all of the magazines in a store or something like that just because they can, because they feel like it. So that would be a manic episode. Three of those things have to be there to be considered a manic episode or even a hypomanic episode. And then the other swing in that direction would be the depressive disorder. So bipolar used to be called manic depressive disorder because those are the two types of symptoms that we see with it. Now we can separate them into bipolar 1 and bipolar 2. So bipolar 1, the manic symptoms are going to be more common, and the dominant symptom that you come in, gets you into the doctor's office. And then bipolar 2 is going to be categorized more by the depressive symptoms. Bipolar cycling, you can be on these, be in these moods and just kind of stuck there for like weeks or months at a time. They can be brought on by significant events. They are not always, but usually that's just the first event. Okay? It's not, it doesn't just keep happening to the point that, something happens and you get swung in the other direction. So who gets bipolar disorder? Not that many people, but this is one of the few that we're going to talk about that men and women are actually equally likely to get. So yay, equality. I mean, around 1% of the population for both types. Nature and nurture, there is some research to suggest that there are environmental factors as well. Heritability is pretty significant, very high. And for whatever reason, there's a high rate of bipolar in high income countries. I'm not 100% sure how that happens. And there is also some correlation between bipolar development and exposure to viruses, poor nutrition, or stress during fetal development. All right, so this is another one that is very popularly portrayed in media, schizophrenia. If anybody's ever seen the movie A Beautiful Mind, probably not, you guys older than most of you guys. So schizophrenia, categorized by three types of main symptoms. So psychosis, which is a loss of contact with reality. Delusions, which is strange or false beliefs that somebody will believe pretty much no matter what. So like thinking that they're, I think in his video, he talks about like if somebody thinks they're like the Queen of England, or if they were, I could believe really strongly that I was in the movie Jurassic Park, even though I was born in 1994 and it came out in 1993. But if I were having a delusion, if I were deluded, I would believe that anyway. And then hallucinations, which is exactly what it sounds like. These perception-like experiences that somebody believes are real, like the sensory experience to them is real. They are, if they hallucinate another person, they are having a conversation with another person, but other people can't experience them. See the positive versus negative symptoms. Like I said earlier, Positive does not mean good. Negative does not mean bad. Positive means something is being added, similar to our discussion about reinforcement earlier in the semester and punishment. And then negative means something's being taken away. So like on the positive side, you'll see like abnormal, words like that. And then on the negative symptoms, you'll have like decreased, lack, reduced, those kind of things, because it is a reduction of activity instead of a surplus of activity, which would be a positive symptom. All right, so diagnostic criteria, you have to, so this would be according to the DSM-5, you have to display symptoms for the majority of days in a 1 month period. So a month is what we're looking at there. Must experience significant dysfunctions, there's that word again, work, school, relationships, or personal care for at least 6 months. So this has to last a while. Schizophrenia is actually a spectrum of disorders. So you can have schizoaffective disorder, which is pretty much just like the mood portion of it. It's the less significant version. And then schizophreniform disorder, which is sort of a precursor to proper schizophrenia, where a lot of the same symptoms are present. They may be milder, they may not last as long. But a lot of times people who get schizophreniform disorder, it develops fully into schizophrenia. Schizophrenia disproportionately affects people of lower socioeconomic classes. There's another question about why that happens. We're not 100% sure why. There is a stress element to the onset of schizophrenia, which would make sense in the context of people who have anxiety about food scarcity or not having a place to stay, things like that. These 4 ladies all had schizophrenia, but the important thing here is that, first of all, that there was a significant genetic component to it, but they also all had different dominant symptoms. So usually when you get a diagnosis of a psychological disorder, not only will you get a diagnosis of, okay, well, this person has bipolar, but you will get a diagnosis that says what your dominant symptom is, because there's usually something that gets you into the doctor's office, some sort of debilitating presentation of that disorder that is causing you a lot of problems. So we would call that your dominant symptom. But this also underscored how the disorder worked within the context of families, because they basically had 4 different types of schizophrenia, even though they all had the disorder. There is a significant genetic component to schizophrenia. It's highly heritable. If one identical twin has it, the risk of the other one getting it is pretty high. And the person who has a parent with the disorder, risk of persons being diagnosed is somewhere between 10 and 15%, which is also pretty high. We also have this question of diathesis stress models. This is a very important thing in psychological disorders. Diathesis just means like genes, predisposition, and then stress is environmental factors. So going back to our discussion of people with lower socioeconomic status being diagnosed more frequently with schizophrenia, that's part of the problem. If they're having significant like existential levels of stress, that is going to potentially exacerbate those symptoms or even get you in a position where you would have the disorder. Brain, thinning of the cortex and large ventricles, mostly things that are involved with sort of like experiential regulation and emotional regulation, things like that. May not work as well as they would in typical brain and a schizophrenic brain. Also maybe due to long-term medication use. We talked about how different drugs can significantly affect your brain activity. And if you take some of them for long enough, you may develop symptoms like this, even if it isn't proper schizophrenia. So one other thing, probably the most important hypothesis when we're talking about where does schizophrenia come from, is the dopamine hypothesis. So we talked about dopamine in the past, how dopamine is involved in 2 things mainly. It is your reward neurotransmitter, basically. And then also it helps with attention regulation. So if you are experiencing these sort of outside of consciousness episodes where you're hallucinating or having delusions, that might be because you have too much dopamine in your brain. And the reason we found that out is that different types of medication that inhibit the action of dopamine, so they stop dopamine from binding at the receptor sites, actually help to suppress psychotic episodes in people with schizophrenia. So it doesn't cure the disorder. What it does, it kind of suppresses that specific symptom at that time. So it's not designed, those anti-dopamine drugs are not designed to, okay, well, your schizophrenia is gone now. It is very much just trying to ensure that that specific episode is under control. Okay, so there are some environmental triggers, exposure to different kinds of viruses in utero. So when you're in your mom's tummy, complications at birth, social stress, and cannabis use. So marijuana, doing a lot of weed, related to slightly increased risk of schizophrenia onset, which kind of makes sense. All right, so this is one of my main frustrations about this course, and this I could do a whole thing on this, but we don't really have time for it, unfortunately. I wish we did, but there's only one slide on autism for the whole course, and that's really frustrating. Yeah, for a number of reasons. One of which is that my wife works predominantly with kids with autism, and something that is very near and dear to our hearts. But autism, in a very broad definition, you see this is from 2013, is characterized by persistent deficits in social communication, social interaction across multiple contexts, restricted, repetitive patterns of behavior, interests, or activities. So the key thing to remember about autism is that opposed to a lot of these other disorders, which are going to be some type of mood disorder, depressive disorder, social disorder, whatever, autism is a developmental disorder. So it can affect all of those different areas, but it specifically impacts the development of them as you grow from adolescence or childhood into adolescence into adulthood. So it's 4 times more common in boys than girls. There is a question of sort of chicken or egg, which we talk about a lot in this course, of is this because there actually just is more autism in boys, or because autism symptoms typically present differently in boys than girls, and usually a little more obviously in boys than girls. So you have that significant behavioral element to it that usually gets spotted in boys more easily than it does in girls because it presents differently. All right, so this prevalence is also different now. I think it's more like 1 in 45 at this point, instead of 1 in 68. The causes still under investigation, but there is a significant genetic component, we're pretty sure. Okay. Personality disorders. So in this case, we are getting into the cognition, emotional element. We talked about personality a little bit last time. We haven't gotten fully into the personality test discussion, but psychological disorders that include impairments of cognition, emotional responses, interpersonal functioning, and impulse control. So going back to our discussion of autism 2 seconds ago, there are personality elements to it. So if we're talking about interpersonal functioning, kids and adults with autism usually have issues with picking up on social cues. So that would be if somebody had something like antisocial personality disorder, they might have that same symptom where they don't pick up on social cues well, but they might not have some of the other things that autism affects. Okay, so like personality traits in general, the core qualities of people with these disorders are fairly stable over a lifetime across situations. They don't change much according to the context. There are 10 personality disorders. We're not going to talk about all of them because we don't have the time. 2 that we're going to talk about the most are antisocial personality disorder, or what it would have been called in the past, which is psychopathy. If you've watched a lot of like Criminal Minds or Mindhunter or whatever, like this is pretty common in different types of media. And then borderline personality disorder. So looking at that, you might think, oh, well, it's just kind of like on the fence, if they have a disorder or not. That's not what that means. We'll talk about what borderline means when we get there. But antisocial personality disorder, psychological disorder distinguished by unethical behavior, deceitfulness, impulsivity, irritability, aggressiveness, disregard for others, lack of remorse. So the key one is the last thing. So people with antisocial personality disorder don't feel bad about what they do. So they may be manipulative. They may even be mean and callous and do things that benefit them. Frequently diagnosed alongside narcissistic personality disorder, but they don't feel a lot of guilt for the things that they do. Not super common. It is common in prison inmates. It's more common in men than women, partly because it's more easy to spot, because usually we diagnose disorders that have more like aggressive or behavioral elements in men, we diagnose more disorders that have more emotional components than women, partially because our society has a lot of stereotypes baked into it about the way that men and women are supposed to behave, but that is a different discussion. Heredity plays a role, and then there are brain abnormalities in the frontal lobe, or a lot of complex emotional processing, and that sort of internal determining of what is good and what is bad happens. So borderline, distinguished by incomplete sense of self, extreme self-criticism, unstable emotions, feelings of emptiness. So there's this need for closeness in relationships, but also this need that goes alongside it with somebody with borderline to push those people away. This is more of an emotionally centered disorder. Like I said, that is one of the reasons that it is more often diagnosed in females. Again, I'm not saying that's right. In fact, I think it's probably not right, because there are definitely more men with borderline than we realize. But that's just part of expectations, which we've talked about in our social psychology unit. Childhood trauma also may be a trigger for borderline. Right, dissociative disorders. There's a couple that we're going to talk about. We've already talked about one of them, dissociative amnesia. That's where you sort of selectively edit parts of your memory. So if you experience something traumatic, somebody with PTSD, so like a soldier coming back from a war, may not remember the actual like specific details of like a battle they fought in, something they were trying to forget, because of this dissociative amnesia. Okay, so it's disturbances in normal psychological functioning, may include problems with memory, identity, consciousness, perception, and motor control. So you can also have this thing called dissociative identity disorder, which in the past we would have called multiple personality disorder. So if you're watching Moon Knight right now on Disney Plus, that is squarely in the sights of the subject matter for that show. But a dissociation basically is a disturbance in the normally integrated experience of psychological functions, often memory, consciousness, perception, or identity. This is another one where there's sort of a normal range of dissociation. So if you've ever been driving to school and not like consciously paid attention to all the turns you were taking, and then all of a sudden you just like wind up there, it's a 15-minute drive and you were paying attention for like 2 of it, that would be a mild form of dissociation. So it's not enough to be classified as a disorder, but it is still a dissociative state. People who have dissociative disorders experience those states all the time, and to a more significant extent. So dissociative amnesia. So if you were forgetting things in that state, we would call that dissociative amnesia. You can even have a fugue state where you wander, sort of like sleepwalking in a confused and disorganized manner. And then dissociative identity disorder. This is where you get your multiple personalities, 2 more distinct personalities within an individual. There's some question over whether or not that actually exists, but the research that would support it would say that personalities can, like, if you measure one personality, it would have X blood pressure, or have X dominant hand. And the other personality would have a different one. So you have actually like physiological characteristics change between the personalities, and even sometimes physical characteristics. So what causes them? A lot of childhood trauma causes this, sometimes neglect, war, terrorism, things like that, exposure to those ideas. There's a question of, do clinicians reinforce the development of these dissociations? There's a really famous case study. If you've ever, I don't know what you would have, but if you've ever seen the movie Sybil, Hank talks about this in his crash course video. This very famous case where this woman, extremely famous case study that the psychologist put out about this lady who had, I think, 16 different personalities, and she made it all up. So and from that, people reading about that case and hearing her story, watching the miniseries, whatever, there was like a huge jump in the number of diagnoses of dissociative identity disorder, even though, like I said, it was completely fabricated. And so there's a question of clinician responsibility, like, was this the fault of the psychologists, and how often do things like that happen? We're not really sure, but we're pretty sure that's the thing, not sure to what extent. Okay, eating disorders, last thing we're going to talk about. So we're talking about 3 main ones: anorexia nervosa, bulimia nervosa. We probably usually call this anorexia and bulimia. and then binge eating disorder. So this involves restricting or increasing food consumption. There's a significant emotional element to this as well. Again, going back to our perception of psychological disorders through the lens of gender, they typically affect girls. They also definitely affect men, but we usually more frequently diagnose this in women because of societal expectations of how these things present themselves. So anorexia nervosa, this is probably the most common one, definitely the most societally pervasive. So I should add this. This is the most direct psychological disorder that is linked to death. So as opposed to something like depressive disorder, which is like a secondary threat, because like usually death comes through something like suicide, you can actually starve yourself to death through something like anorexia, because your body, you underestimate the extent to which your body needs food to function correctly. So it starts with some sort of emotional disturbance. You can see here depicted in this picture, people with anorexia nervosa, or even any type of eating disorder, most types, actually see themselves differently than the world sees them. So we tend to think that, the way to treat somebody with anorexia is like, oh, let's go eat a hamburger, it'll be fine. But like they literally see themselves incorrectly. And that's why it's classified as a psychological disorder, because that is a cognitive breakdown that leads to that very sad circumstance. So it leads to extremely low body weight, leads to amenorrhea, which is women losing their period, can lead to hair loss, can lead to skin abnormalities, can also lead to death, which is not great. Also affects mostly women, particularly teenage ones. Males can also be affected, particularly those in wrestling, running, or dancing, things that are athletic activities that require you to be of a certain weight. Bulimia, the most important thing with bulimia is the binging and purging element. You've probably heard of that before. So eating a lot and then purging it, getting rid of it. So yeah, feeling that lack of control and then purging returns that control. Then binge eating disorder is just the first part. You can see some of the health threats that come along with both of these. High blood pressure, type 2 diabetes, so that's the diabetes that you're not born with, heart disease, electrolyte imbalance, salt imbalance, and then decaying teeth. All of those can come from eating too much. So, but there's no attempt to purge with binge eating. Then this is just a list of things that you can do to treat eating disorders. This is all under the correct impression, that eating disorders usually have some type of underlying emotional condition that is leading to their proliferation, which is true because it's harder to treat the actual physical symptoms. So like I said earlier, it's not necessarily adequate to, even if you give somebody a transfusion of nutrients that they're not getting from food, if they are, if they have some sort of emotional cause that is creating the symptoms associated with the eating disorder, that's not going to help. And so getting this more comprehensive approach to therapy, so like counseling, being in some type of group setting, healthcare, monitoring their the vital signs, all that kind of stuff, and then drug therapy. So if you can actually treat the underlying emotional condition, so if it's depression, in theory, if you treat the depression through medicine, you would be able to help ameliorate the symptoms of that eating disorder. Okay, that is the fastest I've ever broken down any of that stuff. So congratulations for being a part of that. I know there are probably some questions outstanding about all of the stuff that we have between now and the end of the semester, which is May the 2nd, by the way. So we are 2 weeks away from wrapping this thing up, which seems insane, but that is just kind of where we're at. Got a late start and have had to play catch up pretty much the whole time. So we are going to have our test this weekend. It's the same kind of deal as normal. So all open note. You will have to use HonorLock, but I will open the test up probably tomorrow. And then if you have any questions about that, please email me and we'll get that fixed as soon as we can. Trying to think what else. paper, we'll talk about that. I'll probably put out an actual video about that, put it on the YouTube channel that there's a link to on Blackboard. Yeah, I'll hang out here for a minute after we officially wrap up here in a second to answer any questions that I can answer in this time. But other than that, I know you guys, a lot of y'all have to get to the school. So if you don't have a question, I will see you soon. I don't know when. It's the last time we meet, but yeah, bye.